Hello and welcome to the HIV Cure podcast. My name is Sakabo Marumo, and yes, it's been such an interesting journey this season. Today we bring you a special episode, the season finale. We have learned so much about HIV science, community, access to treatment, prevention, HIV cure, and your role as an advocate, as a researcher and policymaker. Today, we're talking about HIV without access. We're going to dive more and examine how breakthroughs in HIV treatment, prevention, and long-acting therapies like Lenacapavir risk leaving communities behind if now access is not addressed properly. This episode, we're going to just highlight the critical link between scientific progress as well as equitable availability. And we are going to be featuring insights from ITPC on advocacy, patents, and we are also going to talk about the role that community-led advocacy has when it comes to ensuring that there is equitable access today while we're also preparing for a future HIV cure. So let us welcome our guest for today. Hi, Solange. Good morning.
Hi, good morning. Great to be here. Thanks for having me.
Yes, I can't wait to dive more into the questions. Thank you for making the time to join us and just break down this episode, the season finale with us.
Most welcome.
Yes, kindly just introduce yourself and the work you do.
Sure. My name is Solange Baptiste, as you have already introduced. I am the Executive Director at ITPC Global, ITPC, International Treatment Preparedness Coalition, but it's now called ITPC. I'm saying that for those who might have a history with ITPC since we started in 2003. So we have been in this game for quite a while, and our roots are in South Africa, but ITPC actually had an office in Botswana. We were registered there. So we have an affinity and affection for Bots as well. So thank you for making the time to hear from us on this very important topic of access to medicine.
Wow, it's very interesting that you had an office here and you started in 2003. So I'm a young person who's openly living with HIV, and I started taking treatment in 2003. So that's quite interesting, and yeah.
Look at that.
And now when what we are talking about is that the promise behind long-acting treatments is they were seeing it. Research shows that it's working, right? And we've seen that the HIV science has made incredible strides when it comes to ARVs, and now we're talking long-acting prevention. Back early in the 2000s, I used to take around like 7 tablets in the morning and in the evening, and we saw how that has transformed because of science and change. Now I only take 1 pill a day. But with all these research interventions or breakthroughs that we're seeing, new tools that are happening and technologies, they still unequal access, or access is still uneven across the world. So from your perspective, why does this gap in 2025?
Yeah, that's a really good question. Thanks for that. It is something that might baffle most of the audience today, but I think the short of it is that the gap persists because science runs on innovation, and we are doing a lot of that, and science is leaps and bounds ahead of the access, because the access is governed by power and by politics. So you have things like patents and pricing monopolies and weak delivery systems, right? Those things determine who will get to, who won't get, who will benefit from these innovations that we have. And it's not limited, obviously, to ARVs, but within the HIV space, there are many types of innovations, whether it's from the prevention diagnostics, all the way through to the actual therapies. We've seen this clearly, like when you think about a drug can be developed that wait more than 10 years to be able to access it affordably for all the people that need it within their country. And that's what UNAIDS refers to as the pandemic inequality cycle. So unless we actually intentionally disrupt that, we will keep on seeing history repeat itself. And it's not necessarily just about the drug, right? Or the actual technology. It's related to community-led monitoring showing how fragile health system worsen gaps. So like in Malawi and South Africa after this 2025, so earlier this year, sometimes we're a little bit lost on what year it is, earlier this year with the US government cuts in the response for HIV, testing dropped, according to our CLM data, dropped by 26%, ART initiations dropped by 24%, and viral load testing dropped by 36%, but this was earlier in the year. So it's probably a little worse than that now if we're keeping track. But at the sites that we were monitoring as ITPC, despite medicines being on the shelves, we had these drops in initiations, viral load testing, and just testing generally. So communities were able to see the collapse long before the national data did. So what I'm trying to say here is that inequality is baked into both the pricing and the delivery. So unless you tackle both, you're going to continue to ask me this question: why is science making strides, but we still see uneven access? That will happen because of the inequality that is already within the system.
All right. And when, you touched a bit on, or you talked about innovation, and we did see that in the early days of ARVs that millions were left behind because of cost and distribution barriers that were there. So from all of that happened in the early 2000s, from that period, our most critical, when we now look forward to HIV cure strategies and access.
Yeah, look, I think we really need to build for design with the what you used to call in the HIV space the quote unquote hard to reach, right? They're not hard to reach. We're not actually building and designing for the margins, sort of for the edge, depending on some of the literature that you read. The idea is that you have to bake in access. It has to be part of the whole design. You can't just stick it on at the end after the thing has been built. So we can't wait for generic entry years later. TRIPS flexibilities, voluntary licenses that cover middle income countries, and transparent pricing need to be embedded like at the start, from the beginning, from the launch. You also need to remember that communities are the engine. So CLM is not just this watchdog. Generally, community leadership, right? Whether it is from literacy or it's actual monitoring, getting the data to change what's happening in terms of access, or if it's like research. But this whole idea of just watchdogging, right? But it isn't. Communities have a role to play, almost like a redesign instrument within the system, right? In South Africa, ITPC's CLM showed that poor targeting of adolescent girls and young women. After advocacy, then you had service integration was reinstated, and CLM sites became 50% more effective at finding adolescent girls and young women living with HIV at a lower cost. So you can see that the sort of value proposition of CLM is very high, and we need to be able to figure out how to really embed community leadership and interventions within the system. And I think the third point is around deliverables. Service delivery, things like multi-month dispensing, not just getting every month you get your script and you have to come and line up, but multi-month dispensing, and community-based testing made ARVs workable at scale back in the day. So these cure strategies that we need to think about now must start with the same lens. We have to design for the context and not just for efficacy, right? It's really important to think about the realities on the ground in order for access to take hold.
Over the last 5 years, we did see this excitement that was happening with long-acting treatments, long-acting injectables that, they just became so popular. And over the last 2 years, we did see now even some of the countries that are starting rollouts, clinical trials happening and approvals coming through the prevention tools that are here and that are exciting. So then how do we ensure that these breakthroughs don't just become another example of science without access? And also, how then do we rope in, especially young people, when it comes to community-led monitoring and all of this?
Yeah, absolutely important to unpack that, right? So how do we sort of prevent what I'm just described from happening now with these new exciting treatments on the way? I think the same principle, right? Design, access, and delivery together with science. So things like licenses and pricing. So at ITPC, we fought to expand Gilead's voluntary license for Lenacapavir from a handful of countries to 120, thanks to patent oppositions and pressure campaigns. That is how the access is unlocked. When you think about transparent cost research with, I don't know if all of the audience would know, but Andrew Hills, who is at the University of Liverpool. He is a senior visiting research fellow there who specializes in access to medicines. And a lot of his work is referenced in how we can kind of compare cost versus price. And the idea here is that he showed that Lenacapavir, and his work with ITPC support showed that Lenacapavir could be produced for as little as $25 per year with generics versus the current price in the US, for example, of $28,000. So it's really important to differentiate between cost and price. And nobody's saying don't make profit, but when the profit makes it everything, the access prohibitive, then we have a problem. And then the third part of that, I think, would be around simplifying testing and delivery. So the WHO has guidelines on this. So their guidance stresses, so for example, baseline tests only, multi-month dispensing, and decentralizing injectables as some examples there. But these sort of manage the pricing and use the law to ensure that access is unlocked and that there is generic competition, so prices can be at a reasonable price point, and then make sure that there is transparency between what it actually costs to manufacture and then what the price is, and then thinking about the actual delivery barriers that might be removed. And then critically, I think your point around young people and leading community-led monitoring, I think that's part of the embedding process, right? So it's one thing to embed CLM in the national health system, where we see Malawi being the first country in all of Africa to really embed that in the health system, and committing to do that this year at the Global Initiative as an intention. Part of the embedding has to do with the next generation of leaders. So making sure that young people actually drive community-led monitoring. So communities flagging readiness gaps, clinic queues, the lines to get into for treatment or to be seen by a clinician, issues around fear of needles or confusion about eligibility. All of that can be addressed through the community-led monitoring model, which, takes you from education through evidence through the actual advocacy and engagement. So if CLM is part of the rollout and you think about CLM as part of the service delivery and access lens, then those barriers can be fixed in real time, as opposed to saying, oh, we've seen 3 years and it's not working. Maybe we should ask the community. I think this is where young people, especially as you say, young people living with HIV, can take on a unique and really important role.
Yes, and talking about pricing, we did see, with Lenacapavir that they did say that it's $28,000 per shot, and then through, like you did say, that research, they did say that this can actually be this through generics, we can sell it at this price while you guys are still making profit. And then we also did see recently now they're saying that you can actually get this for $40. So then that also per shot, it questions us as a community, especially young people that want to access these innovations, that what really goes behind all of this. And I want us to talk more when it comes to patents, pricing, and intellectual property that have historically limited who gets HIV medications over the years, and we're still seeing it now currently when we're talking about Lenacapavir, right? how do you see these factors, patents, pricing, and intellectual property influencing who can get Lenacapavir that we've been talking about, that, it's a very exciting innovation, and as well as other long-acting treatments? And then also, how could these factors now shape access for an HIV cure for us to be prepared when that happens?
Yeah, so I think this builds off of the previous question really well. I think Lenacapavir shows the problem, right? High income countries can pay, 24 to 28, thousand per year. Low and middle income countries are left out. Yet the cost of production, according to these studies, is under $30 per year. So the gap is monopoly. It's not actual chemistry. It's not an issue with the molecules. And ITPC has led, and other partners in the space have led successful fights in this. Our Make Medicines Affordable campaign, which is made up of many partners across the globe, especially in middle income countries, had filed about 114 patent oppositions. That's when I talk about using the law. The law is there, but are countries willing to take those risks and pursue this kind of access trajectory for their people? And those patent oppositions that we filed under this broad umbrella campaign for Make Medicines Affordable resulted in earlier generic entry, saving nearly almost 900 million, so about 892 million across 13 HIV products. So not specific to Lenacapavir, right? I'm just talking about the effectiveness of this kind of strategy. We have seen other cases where our campaigns forced other manufacturers to stop enforcing patents, and prices dropping significantly from hundreds of dollars to tens of dollars. So these barriers shape the cure access, because I think that's where this is the Cure podcast. We're thinking about the future and what the cure can look like. These same barriers are going to shape the cure access unless we secure compulsory licensing readiness, broad licenses, and transparent pricing now. If not, a cure would be rationed by income. So we use those classifications of middle income, low income, high income countries. So if not, the cure will be subject to the same rationing by income and by geography. And I can give you two striking examples of how monopolies shape medicine prices, right? So you take Sofosbuvir, hepatitis C cure launched in Gilead in 2014. In the US, it was priced at $84,000 for just 12 weeks of that treatment. Even years later, with quote unquote discounts, it still costed $64,000 in 2020. Meanwhile, in Egypt, where the patent was rejected thanks to civil society action, local companies stepped in. They made the same medicine for just $343, so they still were able to make a profit. And today it is available, available for less than $100. That is the power of breaking a monopoly. So it's not saying, oh, you are going to remove the incentive for innovation if you don't let companies make profit. We're saying make profit, but don't make profit to the point that it's prohibitive and now you are reducing access. You can now fast forward that same sort of principle to Lenacapavir. Gilead's new talking about $8,000 per year. Pricing in Europe is also expected to be as high, around 24,000 euros. And when we conducted the research, as we said, it could be produced for as little as $25 per year with generic manufacturing and proper scale. So there's a whole sort of understanding of how the system works. So these aren't isolated cases. The problem isn't the cost of making the medicine or the incentives to get the companies to make the medicines. It's actual monopoly. So when companies have exclusive rights, they can charge whatever they want. They say this is the price. When those rights are challenged, prices can crash and access can expand. And that is what we're hoping for in this cure trajectory.
Yes, and talking about power, we've seen communities being the change and being the voices, changing things and leading up to access that we're talking about. And to talk more to community led advocacy, we've seen it play a huge role in making sure that HIV medicines are more accessible. I think earlier this year, around April, I watched a documentary of how South Africa, and I think it was ITPC that led the advocacy, for ARVs to be given to the public, and also the the rollout of prevention to mother to child transmissions, that access, that's the power of community, that their voices can bring change, and their voices do bring change. And now the question now is, how can communities now influence the rollout of long-acting injectables, as well as, from all of this, how can these efforts now prepare the world for an equitable delivery of an HIV cure when it comes?
So I think the idea of making sure that we don't see communities as beneficiaries, but really as co-creators of access. Through community-led monitoring, communities are already collecting real-time data on what is working and what is not working. So what is failing in Botswana, Eswatini, in South Africa, across the entire continent of Africa and across the globe. Our dialogues have revealed that it's not just excitement, but concrete concerns. So there have been, in terms of the injectable rollout, right? There are fear of needles, missed appointments. How do you deal with that? Unclear information, the cost barriers, really just very much in the details of concrete service delivery implementation on the ground. But communities also highlighted opportunities. Right? Injectables could decongest clinics. They could reduce pill fatigue, improve quality of life, especially for women facing gender-based violence or stigma in pill taking. So there are many things that can work really well here, but it has to do with each country's context, and even very locally, sometimes the context of who is the sort of in charge and how does the clinic itself work, and what does service delivery and access look like in that local area. I think for the cure, the lesson is clear. If rollout is not designed with communities at the table, which is the lesson of all the things I've been saying, it will fail. Community-led monitoring and communities in the center of the response have to be built into any of the strategies, right? Because we need accountability, and we ultimately need, after I say all these fancy words, trust. People have to trust that this thing is going to work, and people have to trust that they can be going to a point reliably. And I think what has happened particularly in 2025 is people are still reeling from, that erosion of trust, because at one point we were saying, come every day, come for your medicine, or do this and you'll get 6 months or 3 months or a number of weeks of medicines, depending on the country. Take this and it will work. And then we had a full disruption of services, and there was a lot of misinformation and confusion. And now we're saying, no, here we are again with a new thing, come and trust the system. So it's really important that we see communities as change agents as well. And young people can play a very critical role in being able to help others navigate sometimes the confusion, the misinformation, hopefully not so much disinformation that is out there about what the new technologies are saying.
And when it comes to equity, also that it's not just about countries, but also the populations. Like you did mention that when we're bringing these strategies, that we need to look into the context of, it might be countries or even the different populations that are there. So what needs to be done to ensure that young people, adolescents and young people, the LGBTQI communities and other key populations benefit from all these new innovations that are always happening?
Yeah, so the whole point here is that equity isn't automatic, right? We've seen this through line from the start of the epidemic to today. It has to be designed. It has to be built. There have to be incentives with those in power who are making the whole system work to actually solve for inequity. So when you're thinking about the diversity of populations that need to benefit from these innovations, we have to think about community evidence. So we're talking about our community-led monitoring data, for example, show that adolescent girls had lowest pre-exposure prophylaxis uptake despite highest incidence. So after we did targeted advocacy, PrEP initiations increased. So you can get community evidence in terms of your design. What do you actually see there? In terms of service integration, you can think about, pushing for family planning plus HIV services for better integration. And I think every country is now thinking about integration, right? Everyone has less funding and you have to almost do more with less money. And so integration is the topic of the day. So how do you ensure that? You can then have a very targeted approach if you think about different perspectives of varying populations that are affected, to think about what integration looks like, service integration could look like. And then you need a diversity of options. The WHO says, for example, that adolescents and key populations need multiple prevention choices. And we know that also from communities. Not one thing is going to solve for everyone. So you need an oral option, you need an injectable option, you need an implant option. One size fits all will never work and will continue to miss the mark. So we want to make sure that we have a range of options for people. And we want to make sure that those options are real options. Don't talk about an option and then it not be available. So we need to make sure that the choice is not an illusion, but it actually is where people can sit down and understand the pluses and minuses of all the different options. And then they can actually make a valid, informed choice. And then I think about things like readiness fixes, right? So like CLM data, I know ITC's work highlights these gaps of like lack of provider training, like long clinic lines, unclear eligibility. So unless these issues around readiness, our countries, our local communities, clinics able to be ready, unless those are addressed, the inequities will continue to persist. So I guess the answer is start where the inequity is the sharpest. And if the cure doesn't work for those at the margins, it's not going to end AIDS. So we need to be very clear about that.
Yes, and you did talk a little bit about how, funding cuts this year have disrupted everything, systems across the world when it comes to, the HIV response. And I want us to touch more on, funding cuts and global health inequities, that to threaten the HIV treatment and prevention programs. So then how can we protect access today to prevent similar inequities from happening with an HIV cure?
Yeah, I mean, look, the reality is we're in a very difficult place. Many of the health systems are buckling under the pressure of having to fill this gap that has been created from the start of this year. And cuts have gutted services. So I already talked about what we saw in Malawi through our CLM data in terms of testing, ART initiations, all those viral load testing, all those things have dropped. TB cases among PLHIV have doubled at that point in time. And I don't think the trajectory is much better. So the question is, how are we going to now protect funding today within the domestic context? Right? We really need to think about how can we sort of ring fence what we already have as a precondition almost for the cure tomorrow. So if we don't have a functioning delivery system, every cure that we come up with, like the best cure, will remain in the warehouse because we don't have a way to deliver it. So these things have to work hand in hand. And I think it is really important to center this on, different agencies and different parts of the public health system use different language. So they will talk about a people-centered approach, a whole of society approach. If you go to the development financing world, you talk about, people-centered approach. If you're looking at UNAIDS and people power. But at the end of the day, it's making sure that the things that we come up with work for the people that need it the most. And I think centering around community leadership and those that are affected by whatever we're talking about, and this will work as a early warning system to detect the disruptions faster than the government statistics. And it is cheaper than waiting for a collapse and to be like, oh, look, this thing has collapsed. People within the system, if they're already built in with power and agency, can already say, look, this we're seeing the signs. This is the problem here. We need to address this. And it will give policymakers real-time data to act upon. So I really think that is how we prepare for the cure and how we can protect our access today, by building in and embedding community leadership, and in particular community-led monitoring.
Yes, you did give other examples of HIV and or science, how it has advanced, but I want you to give, other examples where science advanced rapidly, but access lagged. And from these, what do they teach us about preparing for a future HIV cure?
Yeah, this is a really, there's so many examples I could think of. I can think of ARVs, as you said, in the early 2000s, right? They were developed in the 1990s, but millions in the global south waited for years and died because of cost and, actually the price. And ultimately, this is why ITPC even started. Then we could think about PrEP and PrEP access in the early 2010s. The WHO recommended that PrEP in 2015, I think it would be, but only by 2024, we still know that, PrEP is a complete failure in that sense. Only 3.9 million people had ever used PrEP. So that's less than 20% of the 2025 target of 21 million, I think it was. And then outside of HIV, we can think of COVID vaccine access, right? In 2021, 2020, we remember us all in that pandemic, and high income countries bought up the supplies while lower middle income countries waited. I mean, I have kids who are under 12 at that time, and ultimately they for COVID. Meanwhile, in high income countries, that was the norm. So the lesson here for me is that equity doesn't trickle down. It's not just going to happen and running down. It has to be designed from day one. So that means you have to get the power brokers and those that design the system to actually respond to the needs of those communities. Design from the start for the margins.
Yes, and we're just about to close it off. That what role do global health organizations, governments, and pharmaceutical companies need to play now to prevent history from repeating itself?
Good question. Global organizations like UNAIDS, WHO, Global Fund need to make equity conditions non-negotiable. So broad licenses, transparent pricing, and CLM in their strategies. That is critical so that they could have those accountability teeth and tools. Governments, I would say they need to use TRIPS flexibilities, prepare compulsory licensing, look at pooled procurement, and embed community-led monitoring into the national quality systems so that they can actually look at pricing and quality in terms of delivery. I think pharma would be an important aspect to look at. They need to publish their costs and not have black boxes everywhere. We need to be able to have a line of sight as civil society in terms of cost pricing, R&D data. They need to think about agreeing to voluntary licenses that cover middle income countries, and they need to see how they can support and enable local manufacture. That's everywhere. We know what works, right? So we had patent oppositions and access advocacy that saved almost 900 million, as I was describing, on that Make Medicines Affordable consortium that has a number of countries, a number of partners across the world. And that savings was across 13 products. So those are levers. They just need to be scaled now for the cure.
Yes. And finally now, we're closing it off. And if you were to give, one message to people living with HIV, researchers, policymakers, and the broader community about bridging the gap between science and access for long-acting treatments and a future HIV cure, what would it be?
Such a simple question. That is a tough one there. Shared is that science alone won't end AIDS, right? It's a much more complicated scenario where we are fighting power, politics, inequity. So the only thing that will end AIDS at the end of the day is justice. So if innovation doesn't reach everyone, it's not progress, right? The cure will only matter if it's available, if it's affordable, and it's acceptable to all, not just a few. And I've repeated in this podcast the importance of designing for the margins, building for the edge, which means communities leading on through community-led monitoring, really accessing these levers of law, licenses, transparency, simplified testing, and funding the backbone of today's response so that tomorrow's cure has somewhere to land. So the final thing I would say is medical breakthroughs are meaningless if inequality decides who lives and who dies. We know that, and we're seeing very exciting new breakthroughs. Now we just need to have the courage to demand the access.
So science alone will not end AIDS. Thank you so much, Solange, for making the time and sharing with us, the work you do and also how we can prepare for, a future HIV cure, as well as advocate for what we currently have, the innovations that are there, the long-acting injectables, and the role that, community has and plays in all of this.
You're most welcome. Thank you for having me. It was such a pleasure.
Thank you to you, our listener, for staying through and, from the very first episode to this one and learning with us, asking questions. And we really can't wait to see what season 2 has in store for you. Thank you for learning and continue listening and, interacting. Thank you so much. And I'll see you in our next season.